So, hello everyone. Yeah, like Lucille said, I've had I don't know if it's a privilege, but I had the experience of, in 2004, we had an outbreak in Luzanne in southern Mpumalanga, where there was 1,600 cases. And that was at Barberton Hospital, basically, where I was working. And then the ones in Bushbuck Ridge in 2009 ended up having more than 6,800 cases in Mpumalanga, and in total more than 12,000 cases. So I think it's quite clear that it's something that can spread very quickly, and because it's usually in areas with poor health and hygiene and water supplies, it does spread quite a lot. So yeah, like Linda mentioned, the national guidelines, they were recently updated, and they are available to anyone. So I would just like to mention a few things, a bit more practical regarding the management. So like Linda mentioned as well, very important, we need to know what the case definition is. If you don't know what the case definition is, you can't actually know whether you should manage. So it's very clear, actually, as a person with acute watery diarrhea, either presenting with that or a history that he died from that. And they can have watery vomiting or not. And then a confirmed case will be once you have a positive specimen. So luckily for us, about 80 to 90% of cases are asymptomatic. So we're only seeing the more severe cases. And it's really, when they say rice watery diarrhea, that is exactly what it is. It's difficult to explain anything other than that. It is really, if you've cooked water, that grayish color, there might be some solids in it, and it's got a very distinct smell. So once you've smelled cholera, you will always know how it smells. A lot of patients have vomiting, especially in the beginning. There's usually no fever, and some will have stomach pains and muscle cramps. So it's very important to remember just to take a swab. So either a rectal swab or a stool sample, and even if it's post-mortem, still do a rectal swab. Okay, so the standard operations that they recommend there, this is just a little bit of a expansion on that. This really needs to be a team approach, and every facility in an area where there is cholera needs to have a group that's helping coordinate. You need healthcare workers in there, you need your laboratory, you need your community workers, your local clinics, and the local infection control committee, and obviously the Department of Health from that region. It's important, you need to start triage the moment a person arrives at the facility. And then preferably have a short stay area, and then have enough doctors to cover a designated cholera ward all the time. You need to educate your staff. So basic PPE and hand hygiene is adequate. So it really does spread, fecal oral. So masks are not essential, but in general, staff feel much better wearing masks. But definitely gloves and the regular hand washing, good hand hygiene. Also important to speak to the cleaners. They are dealing with the really bulk of the contaminant. But just to explain to them, if they are following good hygiene, wearing their PPE, they really don't need to be scared, and they can help manage these patients. Like I already mentioned, triage starts from the moment a person enters the facility. So even the security guard should be able to know, look, this person looks sick, go straight to the emergency unit. But also there should be healthcare workers nearby already that can allocate them either to the cholera area or to the regular hospital or clinic. And then really it needs to be experienced healthcare workers that assess the patient. And we recommended, what we did is we made a cholera sheet, which already had all the categories, either no dehydration, moderate dehydration, or severe dehydration, and it can just be circled and then kept with the patient. So in that case, can follow up can happen easy. And it's important, let the healthcare worker sign that assess that patient, because that automatically gives some form of responsibility and we've noticed that the quality of assessment improved after we introduced that. And again, take a sample. Really, a rectal sample is the easiest way of doing it in most cases. So take a sample and make sure that you have a line list, and that any person that clinically meets the case definition goes on the line list. And if you suspect cholera, you treat it as cholera. Don't wait and think, oh, maybe it's not that severe. Just treat it as cholera. Okay, so I think the biggest mistake that gets made is that people completely underestimate the volume loss. So in countries with endemic cholera, Haiti, India, places like that, they've actually got cholera beds, which is just a bed with a hole in it and a bucket at the bottom. And that then gets changed every 2 to 4 hours. It gets measured and they know how much more fluid to give. We don't have that. But we still have to find a way of estimating the fluid loss. So using nappies is quite useful. Even for adults, put nappies onto the critically ill patients and then weigh that. We worked on roughly just on 1 gram per milliliter. It's probably underestimated, but that was a more accurate than just eyeballing it. But really record every time a person has a loose stool or has diarrhea. And again, we used one form for observations where nursing staff could record every intake, every outtake, not different pieces of paper, because the volume gets a lot and people feel overwhelmed quite easily. So fluids really is the thing that's going to save lives here. And we all know, you do existing losses, so your deficits, plus your maintenance, plus your ongoing losses. But I can't stress enough that you underestimate the loss in cholera. If we see a trauma patient, we give 500 ml bolus, and we think, oh, we gave a bolus. But if we look at just for the existing losses, so the deficits, for a severely dehydrated person, so a shocked person, saying he weighs 70 kilograms, will need 100 milliliters per kilo over 3 hours. That will mean 7 liters in 3 hours. So giving that as 2.1 liters over 30 minutes, so at 4.2 liters per hour, and then the rest almost 5 liters at 2 liters per hour. So this is massive amounts we're talking here. So, and we all know that our healthcare situation, we don't have IVAC sets, we don't have infusion pumps and pressure pumps and things like that. So really just make sure that you've got 2 well-running large bore IV lines. Make sure that your infusion sets are 15 to 20 drops per milliliter set, and have your vacuometers nearby. You can't, once that starts running out, now have somebody walk to the storage to go and find some more Ringer's lactate. And it's estimated that you need to prepare for 8 to 10 liters per patient. Then for children, really kids under 10, I'm always a bit more scared, obviously, about how we give the fluids. So really, they're shocked. Rather just sit next to them, do the pull-push method of giving 10 to 20 mils per kilo as quick as you can. And then the rest you will give either over 30 to 60 minutes. And then that really needs to run through an IV infusion pump. If you don't have that, you need to use a Diloflow or a Beritrol, and just monitor them very, very carefully. So while that first bolus of 3 to 6 hours is running, you really need to check that kid every 30 to 60 minutes until they are not dehydrated anymore. At any stage, when you see a patient is really looking so much better, they're not having a lot of diarrhea anymore, there's no signs of dehydration, but the fluids that you calculated is not given yet, you can always decide, look, I'm reducing this. So don't think, well, it was the calculation. The old saying of we treat the patient and not the numbers. So just remember that. And then also we want to go back to oral feeds and oral fluids as soon as it's tolerated. So once they're awake, they're not vomiting and they can sit up, then it's really time to to start with oral feeds and ORS. Obviously, we don't want a chance of aspiration or anything like that. And really, babies, try and let them breastfeed, let them drink throughout the process. I must say we saw very little infants. I think it's got to do probably with the fact that they are breastfeeding, and if they're using formula, most caregivers are at least aware of the fact that you boil water before mixing the formula. So if we look at the severely dehydrated patients, these ones really, I mean, they're in shock. They're lethargic, they've got weak pulses. They look like respiratory distress, and this is often due more acidotic breathing. But it can also be a patient that's not so severely dehydrated, but they're not able to drink, but their skin pinch is still slow and their eyes are sunken. I would really recommend doing electrolytes and kidney functions, and preferably a blood gas on all of these. This to us was the cholera outbreak was a good opportunity for a district hospital to emphasize the need for a blood gas machine, because you want to look at potassium, but if your turnaround time is 3 and 4 hours, that value is useless by the time you get it. So yeah, just hypokalemia is such an important contributing factor to death here, I think. And it's not really mentioned in guidelines generally. But once a patient is severely dehydrated with signs of shock, they need to have their potassium assessed. So Ringer's lactate is the IV fluid of choice. We used half-strength Darrows for children after the initial bolus. So the initial bolus would be the 30 mils per kilo would be Ringer's lactate, and then after that we would go to half-strength DD. And that thing, I think every department can make their own decision. It's just with kids, obviously the risk of hypoglycemia is much higher. But you can also make a 5% dextrose solution by just add 50 grams of dextrose to a liter of Ringer's lactate. And by that you will help avoid hypoglycemia. Your other option would be obviously to monitor the glucose carefully and give boluses as needed, but that's very labor intensive and your risk of hypoglycemia is increased. Every facility needs to have a plan regarding their potassium replacement. So really, if the potassium is less than 3.0, it needs to be replaced in some form. What we usually would do is add 20 to 30 millimoles of KCl to Ringer's lactate after the initial 30 mils per kilo bolus, because the rate of the initial bolus over 30 minutes is just too fast. So once that Ringer's is in, then add KCl to the next vacuoliter. You can also decide to run it in one vacuoliter with KCl, one without. If you have more resources, you can do the usual ICU kind of way of giving it in 200 ml bags, but that's really I think up to the facilities to decide. But it's just important. No, hypokalemia is a major problem and it needs to be addressed. Then as well, these patients need to have vital signs checked. They need their glucose checked. They need a urine output monitored. It's easiest really, these are really, really sick patients, just rather put in a Foley's catheter and it can help monitor them for recovery as well, and keep checking for signs of shock. We did not have access to ICU for any of these patients. And in general, if we manage the fluids, we manage the potassium, it's generally, they did well. Obviously, patients with underlying medical conditions is an issue. We need to monitor for overload, especially patients with CCF or renal failure, and especially kids with malnutrition. So the current guidelines always also says antibiotics for everybody. That is useful in reducing the volume of diarrhea and the duration of the diarrhea. But remember, that's not going to save the life. It's fluid that's going to save the life. So these patients are sick, they're vomiting, they don't feel like eating and drinking. So don't stress the antibiotics, but rather stress the fluid. But once they can tolerate it, then give the antibiotics, and do give it orally. Yeah, and you can consider an NG tube as well. And it's just a stat dose of Cipro or azithromycin. So if a patient has some dehydration, so they're irritable, they've got a bit of loss of skin turgor, their eyes are sunken, they've got a rapid pulse, but they're still thirsty and can drink eagerly, this person still needs to be admitted to the cholera ward. In my opinion, it's always better to calculate fluids rather than work on broader tables like this. But if you really don't have the resources, then use the table. But again, you will see this is massive amount of fluids. So it's 75 milliliters per kilo over 4 hours, which means, to try and get a 11-month-old to drink 600 milliliters, that's quite a lot. So really consider putting her in an NG tube and giving the fluids that way. You can also, there's no rule to say you can't give IV fluids to a person with some dehydration. So you can also, especially if people have underlying conditions or you're a bit more concerned about them, place an IV fluid and just give a portion of the fluid IV and a portion of it orally. But obviously, if resources is limited, then you want to preserve your IV fluid only for the severely dehydrated people. Okay. And then also just remember you need to still calculate the ongoing losses and you add that to your calculation of replacement. So what we usually try to do is we calculate the fluid loss. So say there was a diarrhea stool, we think it was maybe 600 mils, 700 mils. We add an extra 700 mils to be taken in the next hour, most 2 hours, but preferably actually 30 to 60 minutes. And then obviously you keep reassessing these patients. So if the patient has no dehydration, this will be somebody that could stay in a short stay ward, but it's important to monitor them for at least 4 hours. These are usually areas with limited resources. People have difficulty accessing the healthcare facility. So don't say, oh, you're not dehydrated, go home. Rather keep them in the area. Again, I prefer calculating the fluids. Usually 5 to 10 mils per kilo can be given, and then the same amount added after each loose stool. Again, there's an easy to use table there. I'm a bit concerned about the above 10 years that says as much as you want. Many people don't feel well. They they don't want to get up and get to the table or the place where the ORS is being given. And the nursing staff is not getting around to everybody quick enough to distribute that. And then they might end up not drinking much at all. And I would really say, so anybody older than 10 years or adults should at least take a liter in that 4 hours. Also important to remember that the small disposable cups is the stuff that we're usually going to use to give this ORS. And that's not a cup. It's not 250 mils. So measure it beforehand so that you've got a better idea of how much they actually are getting. And I would really say just err on the side of caution. So if the stools are frequent, even if they're not dehydrated, or if they're extreme of age, so small babies, the elderly, people with underlying conditions, just rather, if at all possible, admit them or keep them in the short stay area for a bit longer. Don't rush to get people out and then they deteriorate at home and feel that they won't help at the facility and then don't go back. So the amazing thing about cholera is you will have this person in front of you and they look like a skeleton. Really, everything just looks like death is going to happen now. And that's the reality. If you don't treat, that is what's going to happen. And then 48 hours later, they walk out of there. You can't even recognize that it's the same person. And they're completely fine and well and no long-term side effects. So it's a really nice thing about cholera that it affects the gut, but it doesn't affect the liver. It doesn't affect the other organs much, except if you obviously are in shock for an extended period. But really, it's a very rewarding thing to see. But just assess properly and treat them well. And then, yeah, really in 48 to 72 hours, most patients would be going home. we made a discharge paper that we gave to the patient in hand, saying that they were admitted with cholera or that they were assessed for cholera. And then it had all this information as well. So make sure to give health education on how to clean their water, how to manage their waste, and then how to mix the ORS and how much to take at a time. And also educate them so that the whole family knows. So, if it's a mother, make sure she knows how to give to her kids as well, and so on. And then supply enough ORS to last for at least 2 days. So usually 4 sachets for an adult. But just make sure also what kind of ORS there is. The majority you mix in 1 liter, but there's also some that you mix in 250 mils. So just make sure that you are giving adequate amounts. And then also educate them on when to return. So definitely if the watery stools persist, if they become weak, if they're vomiting, can't take the ORS, or if it becomes bloody stools or fever, things like that. Okay, so there's just the references. As Linda mentioned, the cholera diagnosis and case management was updated in May, and that's very useful. The CDC also has guidelines there. And then there's quite an extensive, they call it a short course, training of trainers on cholera, which was related to the Haiti outbreak. And I think that's quite useful for people that's on the front line to go through.